So the next speaker is Dr. Faith Ihekweazu. I can't still say her last name. So she's our gastroenterologist. As you know, gastroenterological problems are sometimes more bothersome than the neurological problems in Mecp2 duplication syndrome patients. And so she's going to talk about the gastrointestinal problems in Mecp2 duplication syndrome. Dr. Ihekweazu, it's yours.
Good morning. Let me go ahead and share my screen with you all. Okay, good afternoon. I guess it's afternoon there. So good afternoon. It's a pleasure to speak with you all today. First and foremost, I want to extend a special thanks to Dr. Pelavan and the organizers for giving me a chance to talk to you all about this. So today, like Dr. Pelavan said, I'll be speaking to you all about gastrointestinal health and Mecp2 duplication syndrome. First and foremost, I have no relevant financial disclosures. We're not going to be discussing any unapproved or investigational treatments today. We do receive some funding from the International Rett Syndrome Foundation for the development and research around the use of a GI health questionnaire, but that won't be particularly relevant today. Okay, so our objectives today will be to review the nutritional and the gastrointestinal problems that present in Mecp2 duplication syndrome. And we are going to discuss some treatment strategies for nutritional and gastrointestinal problems in Mecp2 duplication syndrome. And I've intentionally left some space at the end for questions. So please keep your questions in mind as I'm talking, and I'd be happy to answer them at the end. So let's start with some definitions. Many of you are probably familiar with this term BMI, or body mass index. This is a measurement that's a ratio of body weight to height, and it's a gold standard for measurement for assessing growth and nutrition in our patients. We consider a BMI between the 25th and the 75th percentile to be normal. And we start to worry when patients have a BMI that's less than the 5th percentile or greater than the 85th percentile. I want to bring your attention to something called the suprailiac skin fold thickness. So this is an easy way for us to assess for adiposity or fat deposition, which can give us a really good estimate for BMI. So in this picture, you can see these fancy calipers being used to measure this thickness, but we can just use our fingers and pinch the skin fold in this area to measure. And we want that skin fold thickness to be approximately 1.5 centimeters in width, which is about the width of the average index finger. So you pinch the skin and compare it to your index finger, and this can be an easy way at home that you can assess for the nutritional status of your children. And we like to teach all of our patients how to do this. This actually became really incredibly handy during the pandemic when many of our patients were being seen via telemedicine instead of in person. So it wasn't as easy to get an accurate height in order to assess their BMI status. But at least we could rely on this suprailiac skin fold thickness as kind of an easy assessment to ensure that we were at least on the right track when it came to the nutritional status. When the BMI in a patient is less than the 5th percentile, or we notice the suprailiac skin thickness getting a bit on the thinner side, it becomes important for us to start discussing alternative feeding methods in order to optimize their nutritional status. This might include oral supplements, sometimes nasogastric or even gastrostomy tube feedings become important. Alternatively, if the BMI is greater than the 85th percentile, we start discussing caloric reduction in order to prevent any long-term health consequences from being overweight or obese. At Texas Children's, we looked at 30 patients with Mecp2 duplication syndrome in order to assess their growth and nutritional status. In this group, half of the patients were under 5 years of age, about a quarter were between 6 and 10 years of age, and the other quarter were over 11. We found that the average height was at the 26th percentile, with about 30% of the patients meeting criteria for short stature, which means that they had a height that measured less than the 5th percentile on the growth curve. The average BMI in this group was at the 85th percentile, with 17% being classified as underweight, with a BMI less than the 5th percentile, and 10% reaching the cutoff for overweight, with a BMI greater than the 85th percentile. Patterns of growth can vary quite a bit in Mecp2 duplication syndrome. Patients could have normal height or short stature. Genetic downsizing at puberty might be playing a role here, and we can see anywhere from normal, poor, or even excessive weight gain. And it's important for us to evaluate the proportion of muscle mass versus body fat contributing to weight gain in these patients. So what contributes the most in patients who have poor growth? Whether it's genetic downsizing or inadequate dietary intake is not always totally clear, but we do know that poor chewing and swallowing skills can certainly contribute to insufficient dietary intake. Gastroesophageal reflux, constipation, and seizures can also play a role. We often think about intestinal malabsorption in children who are not growing well, but it's unlikely that intestinal malabsorption is contributing very much here. Recently, Dr. Pelavan, along with Dr. Studer, Dr. Motil, and the Mecp2 duplication team at Texas Children's Hospital published a study exploring the gastrointestinal health in Mecp2 duplication syndrome patients. They conducted a parent survey of 106 patients in order to develop a comprehensive characterization of the GI health in these patients. So over the next few slides, we can look together at what they found. So the majority of patients have some degree of feeding problems. About 71% reported difficulty with chewing, while 77% demonstrated swallowing dysfunction, such as excessive drooling. A bit over half of the patients took more than 30 minutes to finish a meal, which can signify some feeding and chewing problems. And in 30% of patients, the feeding problems led them to have a gastrostomy tube placed. I want to take a moment to talk a little bit about some of the chewing and swallowing problems that we can see in Mecp2 duplication syndrome. So features include poor chewing skills, a difficult time with tongue lateralization or moving the tongue from side to side in the mouth, and formation of the food bolus in the mouth. Pooling of food and liquids in the back of the throat can occur, laryngeal penetration of thin liquids, and even aspiration of liquids. So for these reasons, occupational therapy and speech therapy for oral motor feeding skills becomes critically important for these patients. Back to our study results. About half of patients displayed some signs of reflux, with 50% showing regurgitation and 22% with overt vomiting issues. Only 28% required the use of an acid blocker, and 17% had a history of fundoplication surgery for the prevention or treatment of severe reflux. Interestingly, biliary tract disease, such as gallstones, was seen in about 5% of patients. This is an issue that can be easily overlooked, so it's important for us to recognize that our patients can suffer from gallbladder disease. And gas bloating was an issue in some, with about 15% of parents reporting issues with belching, kind of excessive belching, and 10% of patients requiring the use of gas medications. Constipation was a problem in the vast majority of patients, as we can see here. So 89% had issues with the act of defecation itself. 85% reported large stool size, and 72% reported hard stools. Laxatives were used by about 44% of patients, and probiotics were used in 34%. 3% of patients had severe enough constipation that they required surgery for an ileostomy or cecostomy placement, and about 8% had a history of surgery for volvulus repair. They also asked about parental concerns and found that 85% of parents reported that they worried about their child's stomach or intestinal problems worsening, and 83% of parents reported that they were constantly vigilant due to their child's stomach or intestinal problems. So from this, we can see that there is a significant parental burden due to the gastrointestinal health of patients with Mecp2 duplication syndrome, like Dr. Pelovan mentioned before I started speaking. Bone mass is a very important topic for us to consider in these patients. We aren't honestly sure if the low bone mass is due to low bone mineral content or low bone mineral density, and there is unfortunately not very much information in the literature on bone mass in patients with Mecp2 duplication syndrome. And while we know that patients with Rett syndrome are at increased risk for fractures, we don't know for sure if this increased risk is present for patients with MDS as well. We do know that risk factors for low bone mass and fractures include decreased dairy in the diet, anticonvulsant medications, and immobility, which can be seen in many of our Mecp2 duplication syndrome patients. We can test for bone mass with a special type of X-ray called a DEXA scan. And in order to treat and try to prevent issues with low bone mass, we have to be sure that our patients are receiving adequate calcium and vitamin D in their diet. So what is adequate calcium? You can see here the listed dietary reference intake, or DRI, amounts by age. And what I'll point out is that you can see that we recommend steadily increasing the amounts of calcium throughout childhood when patients are growing the most. And then after 18 years of age, the calcium requirements decrease them. Generally, milk and yogurt are really good sources of calcium. You can think about an 8-ounce glass of milk as having about 300 milligrams of calcium. 1 cup of low-fat plain yogurt has 415 milligrams, and 1 ounce of American cheese has about 175 milligrams of calcium. There are also some over-the-counter calcium supplements that are available as well. What about vitamin D? Well, vitamin D is so important in bone health because it actually promotes the absorption of calcium. We know that patients with darker skin tone, decreased sun exposure, and those taking anticonvulsants are at an increased risk for vitamin D deficiency. In general, exposure to sunlight and consumption of milk are great sources of vitamin D. It's recommended that everyone consume about 600 international units of vitamin D daily. And for reference, 1 8-ounce glass of milk provides about 100 units of vitamin D. We generally will recommend supplementation of vitamin D if the level in the blood is less than 20 nanograms per milliliter, but sometimes we like it even a bit higher than that. All right, let's talk some more about some of the GI issues that we saw are prevalent in patients with Mecp2 duplication syndrome. So we'll start with gastroesophageal reflux. So gastroesophageal reflux happens when stomach contents pass back up into the esophagus. And there are multiple things that can contribute to this, including poor motility of the stomach and the esophagus, dysfunction of the lower esophageal sphincter, which is a valve that's located at the bottom of our esophagus, and it's supposed to keep food and fluid content in our stomach and out of our esophagus. When patients are suffering from reflux, we can see a number of symptoms, including irritability, nighttime awakenings, vomiting, wet burps, regurgitation, feeding refusal, and even respiratory symptoms like coughing and wheezing. We typically diagnose reflux just by looking at the symptoms, but there are some tests that we can perform that can confirm the diagnosis, and that includes things like an upper GI series, pH impedance probe testing, and gastric emptying scans. And the gastric emptying scan really just confirms the presence of that delayed stomach emptying that I mentioned earlier that can predispose to worsening reflux. As far as treatment for gastroesophageal reflux, the first thing we want to do is ensure that we're making dietary changes to reduce the acid exposure. This includes reducing the intake of spicy foods, caffeinated beverages, chocolate, tomatoes and foods with tomato sauces like spaghetti and pizza, and citrus fruits like oranges, lemons, and grapefruits. Additionally, positioning can help a lot with reflux symptoms. So it's important to try to keep patients upright for at least 30 minutes after eating when possible. And often elevating the head of the bed to about 45 degrees can be quite helpful as well. When the above interventions aren't sufficient, we often turn to medications, and these can include a variety of different acid blockers as well as prokinetic agents, which help with the delayed motility that I mentioned in the previous slide. Finally, some patients do require surgical intervention, such as a fundoplication. Biliary tract disease includes diseases that affect the bile ducts, the gallbladder, and other structures involved in the production and transport of bile. So symptoms of biliary tract disease include abdominal pain, nausea and vomiting, jaundice, which is when the skin and the eyes turn a yellowish color, loss of appetite, and sometimes even fever. So to test for biliary tract disease, we usually order an ultrasound, but sometimes we need more sophisticated imaging, such as a special type of MRI called an MRCP or a CT of the abdomen. Additionally, sometimes labs, such as a liver panel, can be helpful. In order to treat biliary disease, we can try medications such as ursodeol, which helps dissolve gallstones, but we often need surgery to have the gallbladder removed. Gas bloating occurs when the gas gets trapped in the stomach or the intestines. We often see abdominal distension, and classically, it gets worse and worse throughout the day. This is typically caused by air swallowing, which is also called aerophagia, and it can be aggravated by constipation as well due to bacterial overgrowth. The symptoms of gas bloating include air swallowing, frequent burping, abdominal distension, abdominal pain, flatus or passing gas from below, and diarrhea. The tests we often perform include abdominal x-rays, which can show us all of that gas that's trapped in the stomach and the intestines. We sometimes check a celiac panel in order to exclude alternative causes of abdominal distension. We can sometimes check the stool for ova and parasite infections, and a lactulose breath test can be used to exclude small bowel bacterial overgrowth. Once again, the treatment of gas bloating also starts with dietary modifications. So we often recommend that patients modify the carbohydrate content of the beverages they consume and decrease the amount of sorbitol, which is naturally found in fruits like berries, apples, apricots, peaches. And then we also recommend they decrease legume consumption, as this can be very gas producing. We can decrease dairy intake or add a lactase enzyme to help with lactose digestion if that's an issue for a patient. And if celiac disease is diagnosed from a screen, then we will definitely start them on a gluten-free diet. As far as medications are concerned, we can try anti-gas medications like simethicone, antibiotics to treat bacterial overgrowth such as metronidazole, probiotics, of which multiple are available over the counter, and laxatives such as polyethylene glycol, mineral oil, lactulose, milk of magnesia, and senna. As we saw earlier, constipation is the most common GI issue that our Mecp2 duplication syndrome patients deal with. Constipation is described as having difficulty with bowel movements, and this could be related to the frequency of the bowel movement, so only having a bowel movement once a week or every couple of days, or the difficulty actually passing the bowel movement. So maybe they're having bowel movements daily, but they're really straining to get the bowel movement out. There are multiple possible causes of constipation, including the most frequent, which is functional constipation, neuromuscular issues that can lead to constipation. There can be endocrinologic problems like thyroid disorders, as well as certain medications that can increase the risk for constipation. The symptoms of constipation include infrequent bowel movements, hard stool, sometimes with blood, straining with the evacuation of stool, abdominal distension, abdominal pain, increased gas, urinary tract infections when constipation gets pretty severe, feeding refusal from their belly just being so full of stool, vomiting, and even seizures. Some of the testing that we do in the setting of constipation could include a rectal exam, an abdominal x-ray, and a barium enema. Treatment, once again, starts with dietary modifications. So we recommend increasing the fiber, which is often found in fruits, vegetables, and cereals, increasing sorbitol-containing fruits, which can actually loosen up stools, and the addition of probiotics. Physical activity can be really helpful, so we encourage all of our patients to be plugged in with physical therapy. And then there are a few different categories of medications that we use for constipation. We like to call them the softeners, the pushers, and the pullers. So stool softeners include things like polyethylene glycol, lactulose, and mineral oil. And these do exactly what the name says. They soften the poop and make them easier to come out for that reason. The stimulant laxatives, or the pushers as we like to call them, include milk of magnesia and senna. And these medications help the colon squeeze out the poop. And then the pullers include suppositories such as glycerin and bisacodyl or docusate suppositories, and these kind of help from below, pulling the poop out to help the patient get that poop out of their body. Sometimes patients are so backed up that they need disimpaction with enemas or lavage of medications through a gastrostomy or a nasogastric tube. And rarely patients require surgical intervention for refractory constipation, such as a cecostomy or even a colonic resection. So in summary, nutritional and gastrointestinal problems are quite common in Mecp2 duplication syndrome. Our goal is to be proactive in the diagnosis and the treatment to maintain quality of life for these patients. Any symptom that causes parental concern should be evaluated by a physician. And please don't hesitate to have your physicians consult the Mecp2 duplication team for questions. That's all I have, so I'm happy to open up for questions.
Thank you, Dr. Ihekweazu. So, questions. I'll start myself first, Dr. Ihekweazu. So we have, I didn't see them primarily, but I have a handful cases, like in US, they are under age 5, but they have terrible constipation. So they try everything they can, but the poor child cannot poop out. So can that be from the genetic syndrome itself, or that's, I guess, question to me that we are trying to understand. But what else you recommend for the management of that terrible constipation?
Yeah, so I think what I find is that in GI, of course, we see constipation a lot, right? And constipation, I think what a lot of people don't recognize is how common constipation is in, non-affected children. It is just such a common problem for children in general. But yes, it is certainly more frequent in our patients with Mecp2 duplication syndrome. And I do believe that is a cause, likely having to do with the genetic syndrome. What we have to do is just be incredibly aggressive with our medications, with using the suppositories. Sometimes we're using suppositories daily and 2 and 3 different medications in order to help the patients have bowel movements. I find that PCPs are often more comfortable using, one medication for constipation, and then it doesn't work, and then PCPs and patients and everyone get very anxious that we aren't going to be able to treat it. But often, if you get aggressive enough, and we really are very intentional in thinking about the combination of medications that we use, like we'll use a puller, a pusher, and a softener. And then if we're seeing that maybe the poop is soft, but they're just unable to get it out and they're crying and they're straining, that might tell us that they need a little bit more of a focus on the stimulant laxative. Or if, they're able to get it out, but it's just really, really hard, then maybe we need to focus a little bit more on increasing the fluids and increasing the softener component. If they're not, I will often tell parents that if they're not having if we're seeing a constipation as a big issue, if the child doesn't have a poop, every 2 days, then we have to use a suppository, because what happens is these are vicious cycles where once the constipation starts and it gets worse, then it gets worse, then it gets worse. And then the longer you go without a poop, the harder it becomes and the more challenging it is to get that stool out. And so staying on top of it becomes incredibly important. And so we usually have plans that we set up where this is our daily regimen. This is what we do if we haven't pooped in 2 days. This is what we do if we haven't pooped in 4 days. And we kind of have like a tiered approach to how we make sure that those bowel movements are happening and the poop is getting out of the patient.
Yeah. I wanted to highlight that combination, softener and pusher together or others. I think that's very important, that I think what we were getting successful in managing the GI in general for this population. One question?
Noel mentioned this drug that we use, Movicol.
Movicol. Do you know Movicol is potassium chloride, sodium hydrogen carbonate?
Is it an oral medicine or an enema?
Is it from the bottom?
It's an oral.
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 Movicol, Movicol.
I am not familiar with that. That's not something that we use here, actually. Do you find that it's helpful?
Yeah, it works very well for us. We don't use it very often now, but if our son becomes
As a last resort, when he's not pooping, how long do you give this? Do you have any plan? Like, does he take it daily? Daily.
It's a great kind of background.
Got it, yeah. I think it's not available in US, and the ingredients, active ingredients, they don't look like the senna or milk of
That's a
magnesia.
benefit. They're not actually stored in the body, I don't think.
It's also bulking, and it bulks plus gets out, so it's a very common part of the...
Okay, it's commonly used in Europe, apparently, yeah. What's it called?
Takes the water back in the bowel.
The water, okay, so it pulls the water.
Yeah.
I see, yeah, that makes sense. So it pulls the water, it's like a softener, right? Like the...
Yeah, that's similar to the polyethylene glycol,
Yeah.
or Miralax is the brand name here. And that similarly, it's called an osmotic laxative. So it kind of goes in there, it finds the poop, and it draws the water in to help soften that poop up.
Actually, that is the first step in US as well. We start mostly with softeners.
Exactly.
To
So the softeners are generally the gentler versions, but they work very effectively. We do sometimes find that the stimulant laxatives, or the pushers like we call them, can be a little bit crampy. Because they're actually helping the colon squeeze. And so that's why we typically will start with the softeners, which generally don't cause much by way of crampy pain or anything of that sort when they're helping soften the poop.
Got it. Any further questions? Behind me. Question here? No, right? That's right. All right, thank you so much, Dr. Ihekweazu, for your time.
Thank you so much. It was a pleasure speaking with you all.
Bye.